The European Consensus Guidelines for the Management of Respiratory Distress Syndrome was just released, and in this video, we're going to take a peek at it and see what we can learn from this document. So my name's Jared. I'm a neonatal nurse practitioner, a nurse educator, and a respiratory therapist, and I love all this respiratory. That's stupid. So my name's Jared. I'm a neonatal nurse practitioner, a nurse educator, and a respiratory therapist, and I'm going to take a look at this consensus guideline and see what we can learn from this document. So at the very top here, we have all of our information, our disclaimers, our copyrights. We're not going to be making any money off of this, so we're just sharing information here. I'm going to move my little guy over so that's not going to get in our way. And this is a publish before print. So they submit this to the journal. The journal is going to take that, they're going to put it online and make it available for you to use and view and do all the information, all the stuff that you want to do with it before it's published. And we have our list of all the people that were involved in the writing of this, corresponding authors who you need to talk to if you need to get anything from it, and our keywords. Um, on this, it gives us a little bit of a background on what's going on. So this is the 7th edition guideline. So every about 3 years, they go in, they review literature, and they come back and make the group gets together and they decide what's the best practices, what are not best practices, and kind of publish what their findings are. So with this one, we had 60 authors total across 13 different institutions. And when they look at the research that they're evaluating for this paper, they use what's called the grade method. And they list this down here all the way at the bottom after the article, the references. It just shows us the quality of the evidence that they're going to be using in this review. So they have high certainty, low, high, moderate, and low certainty, and very low at just like an ABCD scale. And then if it's a strong or a weak recommendation, it's a 1 or a 2. So you're going to see things that are listed as like A1, A2, or D1, D2. It just means that it's either a strong recommendation with good evidence behind it or a weak recommendation without a lot of evidence, or it's kind of based on experience, not really supported by research. But that doesn't necessarily mean it's a bad practice. They're just kind of declaring their level of uncertainty or certainty with the specific item. So going back here up at the top, so I don't want to miss too much of this. So we have our abstract here. They have this box here that just kind of gives a disclaimer. It's over top of this, which I imagine they're going to fix when they end up publishing this one for good. But um, that's just sometimes you'll see that in preprint, but they're probably going to fix that, or they'll most likely be fixing that. Now we're going to go through this article. We're going to look at each recommendations and kind of see what we can take away and what we can learn through this. So at the very beginning, okay, that's what it was. Now, looking at this article, we have kind of a summary here. So, our introduction section just gives us some guidelines about the severity, um, so now it's just a standard paper. It's formatted a little weird. So this would be like the introduction section where it would come after it, but it just looks a little funny because it's a preprint. But we just get like the epidemiology factors here, talking about how many infants are born at low birth weight, how many are born at certain gestations, what they need, and just talking about some of the specifics that that we know about this um, patient population. They talk about some of the changes that they make. They talk about specific ones here. But now we're going to get into this stuff that we really want to learn about. Now, the first section we have here talks about prenatal care. So we know what happens in the NICU is important, but what happens in the hours or days leading up to that delivery are also important. So we have a lot of different factors that we talk about here. So the big ones are preventing preterm birth. So respiratory distress syndrome is a disorder of preterm birth, and if we can, avoid preterm birth altogether, then great. We can kind of stop that from developing. But not always are we able to do that, and sometimes babies can come out. So we talk about what we can do. So um, progesterone for a short cervix for singleton pregnancies is one of our A1 recommendations. Prenatal care, because we know what happens in the NICU matters, but the events and the time and the care that these infants get leading up to that delivery is also just important, because we can do a lot of things to improve the likelihood of or the outcomes that we want. So, first up on these recommendations for prenatal care, mothers at high risk for preterm birth should be transferred to a center with experience, so B1. So, it's a pretty good recommendation here. And we can just say with this one, experience matters. So if you're going to have a preterm infant with respiratory distress syndrome, you want to be at a center that's experienced at handling that versus one that isn't experienced. So make sure you go where you should be going. Recommendation two: ultrasound screening in cervix of high risk pregnancies for women with short cervix. Vaginal progesterone treatment in singletons to increase gestational age at delivery and reduce mortality and morbidity. So giving vaginal progesterone, if we're able to give that to delay delivery and let these kids grow inside the mom longer, perfect. We should be doing that. A1, highest level of evidence. Next is women with preterm labor, cervical length and accuracy biomarkers should be considered to prevent unnecessary use of tocolytic drugs and antenatal steroids, so B2. So we want to make sure that we know exactly how old these infants actually are when we do like dating and different systems that we have, their calculations, because we don't know exactly when like conception versus implantation and all those things happen. We have some pretty good, and we can be pretty accurate, but it depends on the mother being accurate about what time that conception happened versus implantation, and usually there's a little bit of a window there. So there can be some inaccuracies with that. There's other markers that we're going to use to test, like amniotic fluid, so we can see the infant's um, actual gestational age based on different biomarkers. But we want to make sure that we're being accurate as we can when we're assessing these infants. Next up, we have offering a single course of antenatal corticosteroids for high risk of preterm labor. For viable infants, 34 weeks gestation, ideally 24 hours of birth, A1, so highest level of evidence. These infants, if they're going to be delivering prematurely, they can get these corticosteroids. But the complication with that is we can't give any medications directly to that infant. So what we'll have to do in this situation is administer it to the mother. And administering to the mother, it's going to get in her bloodstream. It's going to circulate through her body. It's going to get to the placenta. It's going to transfer to the baby. Then the baby can receive that, and it's got to go through their body as well until it gets to the sites that we want that to work on. And that takes time. There's a lot of steps in that process. So if we're able, um, it takes about, what we're recommending is you need at least 24 hours. So if you give it at 6 hours before birth or 1 hour before birth, that doesn't exactly have the time to circulate through mom, metabolize, get placenta, transfer to baby, and actually do the effect on the baby. So we want to be at least 24 hours before birth. And the next couple kind of flow into that as well. So we talk about repeating corticosteroids for infants before 32 weeks. If you gave it course 1 to 2 weeks earlier, so A2, so pretty good recommendations here. So repeating corticosteroids for infants below 32 weeks, pretty standard. Um, Single dose should be threatened premature weeks. Yeah, we already covered that one. Magnesium sulfate for women's with imminent delivery before 32 weeks gestation, A1, so highest recommendation here. Again, magnesium sulfate is neuroprotective for our infants. So making sure that we get it to these mothers so it can get to these babies is going to be helpful for them to prevent some of those complications that we don't want to see with them. And then short-term use of oxytocin agonists or calcium channel blockers for tocolysis in preterm infants to allow a course of prenatal corticosteroids and transfer. The longer we can keep these infants inside their mother, the better. They're going to have time to grow. If we have to give them corticosteroids, it gives time for the corticosteroids to do their thing, transfer the baby, and do everything that we need it to be. So that'll allow us, hopefully, it's essentially buying us time. Again, these are pretty good recommendations. It's B1. It's um, not the best, but it's, we're pretty confident that that's going to be helpful there. So yeah, doing anything we can to delay delivery, to let the mom either get to an appropriate center or for corticosteroids to do their thing are going to be. The next section we have talks about delivery room care. So a lot of stuff can go on to the delivery room, and here in the United States, we usually just follow our NRP guidelines and then whatever quality improvement the center has done, kind of to enhance that a little bit that way. So we have a couple things that we talk about here. So we have six, and you can see here it gets a little bit more messy. We don't have the straight A1s and B1s and B2s here. So this one's a little bit differently. So let's go walk through these. So the first recommendation, if the condition allowed for cord clamping for 60 seconds or longer. A1, that they missed a bolding, but that we're not going to pick hairs on that one. If stabilization with the cord intact, physiological based cord clamping can be safely undertaken. Longer deferred cord clamping is preferred, especially less than 34 weeks. A1, if it is not feasible, considered cord milking for gestational age greater or equal to 28 weeks. Now, this goes a lot with what we talk about in NRP a lot. The new latest edition that we put out that was released covers a lot about cord clamping. The longer that we can do it, the better. They recommend also at least 60 seconds. They don't necessarily talk about physiological based cord clamping. That's kind of newer, or I guess it's older, but they're trying to bring it back. It kind of can get some misconceptions depending on how it's taken by like the general public or non-medical professionals, but it is good to delay cord clamping as long as we can, as long as it's feasible and as long as it's not going to be creating any risks to the infant. Now, they do end here talking about cord milking, which is something that came new in NRP this last edition as well, where they also recommend for infants over 28 weeks gestation. They specifically say non vigorous infant, cord milk, and then begin resuscitation, but not doing that for infants less than 28 weeks gestation because the evidence just isn't there that we can say if it's going to be safe for them. Because when we're essentially doing that milking, you're going to squeeze the cord, push it towards the baby, and is going to give them a bolus of blood from that cord into their body. And the bolus of blood can go up to their brain. It can cause them IVHs because they still have that really fragile brain and germinal matrix and everything. And that's going to be a very high risk area for injury. So this goes along with what we're seeing in most other places. Recommendation 2, use a T-piece resuscitator rather than a self-inflating or flow-inflating bag. I'm just going to pause there for a second and let it sink in. This should have been standard for a long time. The benefit of the T-piece resuscitator over the self and flow inflating bag is that it is pressure regulated and pressure limited. So this will stop pressures from exceeding what you are set at. And I know a lot of practitioners that just love anesthesia bags, self-inflating bags. I mean, I I think they're just one step above of like mouth to mouth, or I'd say garbage almost, but they have a place. I would never say get rid of them altogether because there have been times where I don't have anything with me and that's all you can use. So great, it's better than nothing. Flow inflating bags have been debated for a while. Oops, there's some research and a lot of it is about expert opinion, where they say that if I'm bagging with an anesthesia bag, I can feel that balloon when I'm squeezing and it can tell me about compliance and resistance and blah, blah, blah. And I always say, that's great and everything while you're there. The big problem with this one is when you're not there and we have somebody who's less experienced or less able to provide manual ventilation. Now, the T-piece resuscitator is different because you set your PIP, you set your PEEP, and it's going to stay at that exact pressures unless you actually physically change the machine. So pressure regulated, it's great. It's going to help prevent pneumothorax and a lot of those problems. We talk about this later, but yeah, use your T-piece. Pretty common. Most centers should be using it by now. Breathing should be stimulated C2 and supported with CPAP A1. A spontaneous breathing does not occur in 30 seconds. Start giving ventilation breaths. Expert consensus is to start with the CPAP of 6 and a peak pressure of 25. All right, we got a lot in here to unpack. So stimulation is important to getting these infants to breathe, to kind of get them started. So making sure we're giving adequate stimulation. Surprisingly, there must not be a lot of research into this area because it's got a pretty lower recommendation. I mean, it's not like they're not guessing by any means. There's some research on this, but stimulation's pretty risk reward. I'd say go ahead and make sure you're using it adequately. If it does not begin in 30 to 60 seconds, start giving breaths. This is pretty standard. Just make sure you're doing your NRP algorithm, do your Mr. SOPA steps, and if you're not, or I guess they're not steps anymore, interventions we'll call them. But make sure you're doing those. And if the infant is not able to spontaneously start breathing, make sure we make changes there. The next one's kind of interesting. And this does probably in this whole section has the lowest recommendations, but your D2 here is starting with a pressure of 25 and a PEEP of 6 or a CPAP level of 6. So NRP has opened this up and they kind of give us some ideas where they say if your gestation's below a certain point, we're going to start with a higher pressure. And if you're above, we can start with a lower, and they give you that range of 20 to 30. So this kind of goes in line with it. They don't recommend starting with 6, but a lot of this is center based. It's based on what your facility has agreed on and doing that. A difference between 5 and 6 on your CPAP for just doing NRP at the delivery room. I'm not going to split hairs over that and just say that's great. Whatever you want me to start with, we can start there. And starting at 25 again, that's the middle ground, pretty safe spot. And then I think that's another reason, if you go back to the last step, why people did like flow inflating bags is because you could look away and not really see what pressure you were delivering. So you were going a little bit higher in your pressures than what you had really thought you were delivering. And then the baby responds. So maybe that was in the 25s and that's, their standard was 20 and, just happened to give a little bit more pressure here and there to open them up a little bit more. But this one's pretty standard. It doesn't conflict a whole lot with what NRP is saying. But the next one's a little different. So oxygen for resuscitation should be controlled with a blender. I think that's so universally accepted that there's not even a reason to put a recommendation there. But here's it gets interesting. They say start with 60% for infants less than 29 weeks, 30% for 29 to 31, 21% for 32 and above. Adjust oxygen based on pulse oximetry, and we should be reaching 80% or more and a heart rate over 100 within 5 minutes of life for babies less than 32 weeks gestation. So not clear-cut recommendations here. This kind of goes pretty close with what NRP has been teaching in their latest edition. So they also agree on at least the full-term infants being started at 21% oxygen, because ventilating the lungs is more important than getting oxygen delivered to the lungs, because once they just get standard atmospheric oxygen from spontaneously breathing, they'll be fine. But it gets a little tricky here when we talk about the preterm. NRP gives you the options of going a little higher on your oxygen levels for infants. They don't say specifically to go up to 60% by any means. They say you can start at 30 or a little bit higher. 60 is awfully high. I know they picked that 60% oxygen level because that's technically what we understand in the respiratory world as the toxic level of oxygen administration. So we definitely don't want to be giving infants too much oxygen. 60 seems awfully high. And this one's going to be a little tough to digest because we know oxygen's important, but early delivery of too much oxygen is going to be a little risky and dangerous. So we're going to have to see a little bit more about how well that's going to be taken. And then lastly, this one talking about using our oxygen pulse ox titration tables, which is completely fine. It NRP breaks that down to a little more minute by minute. But again, we just need to make sure most people or anyone going to a resuscitation of an infant understands that the pulse ox isn't going to be a normal pulse ox for these infants until we get a little bit older. So about 10 minutes of life or so. 5 minutes and 80% is pretty good to remember. NRP breaks it down more, but we have to remember why that's happening. So we have our fetal shunts that are great before we're delivered. They have to be there after delivery. They need to shut. That way we can oxygenate the lungs, give blood to the lungs. That way we can oxygenate the body. And the shunts, when they close, it's not snapping shut like you're closing a door. They kind of constrict. So that's why we're not going to see a great pulse ox on any of these infants until about 10 minutes of life. Just giving us that weird 80 at 5 minutes, and not weird, but it's easy to remember. So, we can just say 80% at 5 minutes of life are good. Adding the speculation that their heart rate's also good. So under 100, you'd be doing PPV per NRP standards. But yeah, pretty a little debatable in this one, but we'll see how that one's going to be received. So number 5, we have intubation should be reserved for babies not responding to PPV with a mask or prongs. Use your video laryngoscope and colorimetric capnography if available. Pretty standard. We want to make sure we're trying to avoid intubations if possible, but if the baby declares that our interventions are for respiratory support aren't working, then yeah, we're going to go ahead and have to intubate. So if we're not able to effectively ventilate and the baby does, if we can effectively ventilate and the baby doesn't respond, then yeah, we'll go ahead and make sure we intubate. They talk a little bit here about video laryngoscopes and colorimetric capnography. So that's just that little cap that you're going to put on the tube, and it's going to tell you about if there's being CO2 exchange in the lungs and exhaled, which, I can't complain with that one. If you have it, use it. Video laryngoscopes are a little bit debatable. I think it's more personal preference. There's various research out there that says if you're trained on one method, it can make it a little bit easier or difficult to facilitate doing it with another method. And then there's confusion too about like where you should be looking if you're using the video laryngoscope based on is it a teaching tool? Is it a enhance intubation effectiveness or efficacy? And it just kind of it depends on how you're going to be being used it. And so basically, I'm going to say use what you're good at. Whoever's the most experienced kind of gets that preference, whether it's a video scope or not. If you're training, it can help, but you want to make sure that you're training to use to intubate without the video, and you're using your video as like an assistant tool because when you get in the real world, wherever you may be going, video laryngoscopes are awfully expensive in the like 15 to 30,000 range per scope, so they're pretty pricey, and not all hospitals are going to be able to afford these. So just make sure that we know how to do it without before we start worrying about making sure we know how to do it with. Next up, we have intubation. Oh, we did intubation. So 6, room temperature, plastic bags or dress or wraps under radiant warmers, humidified gases if you can. Take measures to delayed cord clamping and ensure stability, and hyperthermia should be avoided. Super high recommendations here. NRP's been recommending this for many of the previous ones. They take it further and even say that we should be using environmental, so heat or increase the temperature of the room to 78 to 80 degrees before delivery. Hospitals, it's kind of hard because facilities does that, and sometimes I swear that they just tell you they're turning it up and it doesn't, and the room just stays cold. But these plastic wraps are great. We want to make sure we're using them for all the infants that we can. Humidified gas would be perfect. Pragmatically, there's a lot of challenges there, specifically related to when do we start this gas to heat up? How long is it going to take to warm? Um, because if we do it too early and it sits there, they say there's the risk of developing bacteria because it's warm and wet. And it's difficult. There's some just real world problems with figuring out how to provide humidified gas to these infants. And there's not a great system, at least that I'm aware of, that we can provide heated humidified gas. There's heated humidified like high flow devices and some other devices and stuff out there, but in terms of like delivery room stuff, it gets pretty difficult. And then we talk about using measures to make sure that we keep the baby warm if we're doing those like prolonged delayed cord clamping situations. So your thermal mattresses, anything else we can keep the baby warm should be included. And again, keeping babies warm is the most important information. This comes from World Health Organization, that every degree colder these infants get, their chances of all-cause mortality goes up by that much. So everything we can do to make sure infants are not cold is the better, and we should be supporting it. A lot of them are super easy. There's a couple that are a little bit more complicated, like our heated humidification of gas. And then avoiding hyperthermia. Most of these infants, that they develop hyperthermia, it's going to be because we did our warming of these infants a little, or prevention of hypothermia a little too good. Infants don't usually get hyperthermic in the delivery room just naturally. But now our next section addresses surfactants. Surfactants, one of my favorite drugs out there. It's one of the greatest discoveries that we've ever had in neonatology. and there's a lot of hotly debated issues in this. So I doubt this is going to solve any of those debates, but it does give us a lot of really good insight. So, first one is we should give it to infants early in the course of the disease, whilst on non invasive respiratory support. Consider prophylaxis in the first hour for infants less than 28 weeks with early signs of respiratory distress after stabilization with an S, and whilst because we're fancy Europeans and that's how they write. But, anyways, yeah, surfactant. I would agree that all infants under 28 weeks should be just be getting a dose of surfactant regardless of what's going on, but we don't want to give it without indications. But I can count on one hand out of thousands of infants I've seen that would are stable in less than from a respiratory point of view in less than 28 weeks gestation. So we should just go ahead and give this to these infants. Infants less than 38 weeks that or 32 weeks that require intubation for stabilization, surfactant should be given as soon as possible. So yeah, identifying the appropriate patients. So I'd say any patient less than 32, 28 weeks. I'm less than 28 weeks. I'm going to say green light, go ahead and do that as soon as you can within the first hour after life. Because if we delay and we provide ventilation to these infants before they have an adequate amount of surfactant in their lungs, that's when we're going to be damaging those lungs and starting this cascade that will lead to BPD, bronchopulmonary dysplasia. So early surfactant for our appropriate infants, great, perfect. We want to make sure we're doing that. It gets a little bit different now. So we have infants over 28 weeks. We should give it to them with worsening RDS. A protocol would be to give surfactants on non-invasive respiratory support if they have a MAP greater or equal to 6, FI2 requirement greater than 3 or 30%, where lung ultrasound suggests that surfactant is needed. So a little bit to unpack here. So infants that are older than 28 weeks gestation who have respiratory distress, it's probably would be good to give these infants surfactant. It may not be the necessarily root cause of their problem, but it can help manage symptoms. So yeah, we're going to go ahead and do that. They provide these guidelines here of greater than 6 for your mean airway pressure or greater than 30%. And we got to make sure we're being specific here. So these are these infants over 28 weeks. So under 28 weeks, I don't really care what their settings are. I'm going to say they probably should just get it. Over 28 weeks, we got to be a little considerate because there are some risks with the administration of these drugs, administration of surfactant. So we have to make guidelines. Most of these are internal. I've never seen like anyone out across multiple different organizations agreeing to one thing on this. I've seen internal organizations also disagreeing on what they should be. But if you have a need for PPV or mean airway pressure and oxygen, you probably should get your dose of surf if you're over 30 or 28 weeks gestation. Next, we talk into some administrative type thing. So use a catheter with a laryngoscope C2. So not exactly the highest ratings or recommendation, but we prefer to give them for spontaneously breathing preterm babies. Okay. So with this one, we just want to make sure that we're maintaining the spontaneous breathing when we administer this. So we don't want to completely paralyze them, knock them out, if possible, to avoid that, because that can cause some possible complications down the road. But using our tiny catheter, that's just how we administer it usually. Um, Actually, no, we usually just administer directly down the ET tube. So why they are recommending this, I can actually, yeah, it came clear to me now. Delivery directly down the endotracheal tube with a viscous solution. Essentially, it's like dipping honey or syrup, not the sugar-free stuff, the real stuff, through a straw, and it can be, while it's ventilating at the same time, it can be easy to give that obstruction. So if you can give it through its own dedicated catheter, you can prevent that obstructions from happening. So that can be a little bit safer if you have the right equipment for that. Supraglottic airway devices can be used for infants or for delivery in larger infants. So yeah, using your LMAs or anything like that. There's a ton of different methods out there. Um, they're all they've got a bunch of different names. They're all forms of minimally or least less invasive surfactant administration. So kind of like that almost non-invasive method. Subglottic airways or supraglottic airways are definitely going to be great for that. Initial dose of 200 is better than 100 milligram per kilograms of poractin alpha. So your CuraSurf, which has, for good reasons, kind of dominated the market because of the way it breaks down its phospholipids and proteins, are real really exceed the other models or brands that we have out there. So that's why they're kind of the recommended one here. They're not even debating that Curasurf shouldn't be done. Um, but this is a good recommendation. Talking next about second and third doses. So we should be giving this if we have a high oxygen requirement and we've been able to exclude other things. The second and third doses are debatable. I wish they would have kind of spelled this out a little bit more and talked about specifically gestational ages, because again, those 28-week gestation infants, I've just seen them do a lot better if they've got repeat doses compared to not getting repeat doses. So I do think we should probably look a little bit closer at this one, giving repeat doses to infants that are what we talk about here at the very top, less than 28 weeks gestation. So it's very good to give these infants a little bit more. But we want to make sure we rule out other things first so we can do that. And I'm surprised they don't mention your mean airway pressure here. They're only talking about high oxygen requirement. And you can see here they're very careful not to note your mean airway pressure or your what is a high oxygen requirement, because a lot of places kind of debate what's a high oxygen versus not. And then lastly, we have surfactant should be used for RDS complicated by congenital pneumonia and pulmonary hemorrhage. So not the highest recommendation here, but if we have to think, this is kind of going beyond the scope just a little bit, because we're talking about infant respiratory distress syndrome. But pulmonary hemorrhage is important because blood can essentially deactivate surfactant. So sometimes they may need to establish their surfactant system with exogenous surfactant. And then looking up here, congenital pneumonia, yeah, sometimes it just can help get their surfactant. Our next section here talks about oxygen supplementation after stabilization. So after we're in the NICU, we have a couple here. So in preterm infants, less than 28 weeks with oxygen, the target saturation should be 90 to 94%, considering higher saturations for infants with BPD or hypertension. Alarm limit should be 89 to 95%. And we should have protocols in place for screening preterm infants for ROP. All right, so we'll just start with number 3. We'll go backwards for this one because that one can't be debated. We definitely need to make sure all infants are going to be screened for ROP, especially the preterm ones. Well, our preterm infants are going to be screened for ROP or retinopathy of prematurity, and that is that complication that can develop after we give too much oxygen to these infants. So while we're trying to make sure we're being kind of conservative with that. So we talked then about target ranges. So there's always this debate about the high or the low oxygen targets. A lot of places have adopted, I'm surprised the research isn't a little higher for this one, using these lower targets for these more premature infants, because the outcomes are a little bit better, especially in terms of prevention of ROP, which is one of the leading causes of blindness around the world, and can be attributed specifically to excessive oxygen administration. And then using a little bit higher for infants with BPD and pulmonary hypertension. Again, oxygen's pulmonary dilator. So yeah, we're going to make sure the pulmonary hypertension infants get it. And then the BPD infants are just complicated. And we just want to make sure that they're not low because they have a ton of comorbidities and all sorts of stuff that go into it. It's rare that you just see BPD. Usually it's, they have a pretty big problem list. And then I'm surprised that they mention alarm limits here, because usually those are set internally. Centers will say you have to, they make it your policy, and you know how policies are at the hospital, but they need to be either plus minus 2 about the top, or they usually spell it out for you. But for this one, it would be 1 above and 1 below their recommended target up here. Usually we do 2 at many of the places I've been at. They use 2 for their alarm limits. And this is when we talk about titrating oxygen. So we do want to keep kind of a tight control of where their oxygen levels are at. They're going to be all over the place, and it depends on a lot of factors. But we just want to make sure we're not chasing our tail when we're going to reach these targets, because it can get really time consuming, especially when you have something in the preterm infant, which is going to be like a PDA that's going to cause some shunting, and your pulse oxes are going to kind of fluctuate all over the place depending on how much blood's getting shunted. So it can make it kind of tough to kind of chase those targets, but pretty straightforward. Even though the recommendation here is pretty low, not a lot of people are going to be debating. And next up, we're talking about non-invasive respiratory support, so non-invasive ventilation. Our recommendations here, we should start it from birth in all infants. All infants at risk of RDS who do not need intubation for stabilization. So that's pretty straightforward. A1, yeah, we should start all these infants on CPAP. Next, we talk about CPAP pressure. So CPAP should be started at 6 to 8. NIPPV, or non-invasive positive pressure ventilation, preferably synchronized, should be used as the primary mode. The ability to escalate to NIPPV from CPAP reduces the need for a mechanical ventilation, which is MV, in some infants. So this one has a lot to unpackage. So CPAP starting at 6 to 8 is a little outside of what common practices for most centers are. Most centers do start at 5, but I'm fine if we want to say going 6 to 8. I'm not going to go crazy over that one. NIPPV is really important. This requires a mechanical ventilator, where CPAP, you can do it through a specific CPAP device or a bubble CPAP setup, which is not going to require a whole lot of extra equipment, or at least technology. You can kind of run that one with just the flow. But being able to escalate from CPAP to NIPPV is interesting. So this means we're going to have to to do this, you would have to have your infant on a ventilator receiving CPAP. And then when you need to escalate to NIPPV, you would just change your mode and your settings or whatever it is. So that's a good recommendation. I'm surprised it's so high. It is good, but it is resource heavy. Ventilators are extremely expensive. And if we had to start utilizing ventilators to give just CPAP to a lot of our infants, the price tag on that would be very, very high. And we're not talking about um, the price of a car, we're talking about the price of purchasing a fleet of cars. Um, so instead of buying just one new ventilator, you'd probably need to purchase like 10 or 15, depending on the size of your facility. So that one would be very difficult. But being able to escalate quickly would be great. Um, if they can, yeah, we'll save that discussion. But all right, so we're talking next about BiPAP versus CPAP. So BiPAP offers no advantage to CPAP alone. A2, so they say they have some pretty good research here. I don't know if I completely agree with that based on just my experiences. I've used CPAP devices where it just cycles between the two pressures, and then you're essentially giving sigh breaths to these infants. I don't know. They say that it helps. I think it helps. It doesn't help, but I do think it helps with some apneas sometimes. But again, if that's the use for it, then I'd say like you're probably not being managed effectively if you're having a lot of apneas in the first place. So maybe that's where we get that recommendation from. That all right, following extubation, synchronized NIPPV can reduce the need for re-intubation and reduce BPD needs. So some pretty good evidence on this one. So this just means using our ventilator, but then extubating, instead of extubating directly to CPAP, extubating to a device that can be synchronized with those infants. So again, resource heavy, but it is good. A lot of people, at least in the, it's different because we don't want to have like a true like scale, like a ladder where infant goes from intubated to this, to this, to this. It kind of has to be different for each infant. It gets a little confused between practitioners because they'll treat all infants the same, and they'll say that after you get extubated, you go to this device, and then you have to do good here, then you go to this device. Um, but for like our preterm babies, so yeah, they might need to do that, but then they'll kind of extrapolate that to our term babies who don't necessarily need that. So it can be a little confusing. So just being specific about what infants we're doing that on. The interface should be short nasal prongs or nasal mask. Pretty good recommendations here. Again, those are the only ways to give it. We would never use a full face mask with an infant. But doing it through the nasal prongs or mask, yeah, I always even recommend like alternating between the two of them since they are equivalent therapies, because that will help you with reducing the risk for your pressure injuries or skin injuries on these infants. So I think that one's a great one too. And then high flow nasal cannula can reduce nasal discomfort as part of a weaning for non invasive support. Again, sometimes people like having that ladder. I don't, we've gotten away from just giving a regular nasal cannula, but it could be possible to just provide that extra flow with a high flow nasal cannula, which is debatable if you're going to be getting any actual pressures from the high flow cannula, but you can be giving a lot of flow and some transient kind of incidental pressures, but they're usually not significant enough to, really be support on that. Mechanical ventilation is the next one, and this is an important section, so let's jump into it. Mechanical ventilation should be used in babies with RDS when other methods have failed, and duration should be minimized. So yeah, our first half of this is pretty strong and solid. If you have an infant that's failing respiratory support that's not a mechanical ventilator, you probably should intubate and provide that support. But the duration should be minimized. It's kind of vague. And I looked through a little bit deeper to kind of understand why they're being so vague with it. And it says we stabilize infants with once they demonstrate spontaneously breathing, they can be extubated to some form of NIV or non-invasive support. Infants may require a short period compared to others that may, infants who have received surfactant should be extubated. When you're on low vent settings, it should be encouraged. They say the factors are complex, which is kind of why they don't make an exact recommendation here because, yeah, they are complex, but they talk about some mathematical formulas, which someday I would really like to dig into that a little bit more. They talk about some methods to predict extubation readiness. They just say don't use your ET tube. Spontaneously breathing ET tube on CPAP are not helpful. Again, they extrapolated that from the adult world. It is kind of helpful with adults, not so much in our neonatal population. And to extubate when your MAP is at 7 to 8 and your distending pressure of 8 to 9 if you're on the oscillator. Balance the benefits of getting off the ventilator. And this is the big one that I think everyone needs to kind of read and think about and reflect a little bit more when we talk about balancing the needs of getting the infant off the ventilator more quickly versus the risks of repeat intubations with ventilation. And just take a second and think about this, because this is a debate that I've ran into a lot with a lot of different providers. Is at one point an article came out, I can't remember exactly when, but it was talking about the dangers of mechanical ventilation, and we should be doing everything we can to get these infants off the ventilator because every single breath is a risk of increasing your rates of BPD. And that's great and all. Yeah, we want to minimize the amount of time infants on a ventilator. The longer they are on the ventilator, the more likely they are to develop some type of complication that could increase the likelihood that they could develop BPD or some negative outcomes we don't want to see. But what they don't seem to grasp about that concept is repeat intubations. So the act of intubating an infant that or performing that procedure can be pretty traumatic to their airway. Putting them back on the ventilator can be kind of difficult because sometimes if you extubate and you fail the extubation, it can cause some problems when you're on the ventilator the second time, because then you're probably in a worse spot than you were before, because if you've declared you need a mechanical ventilator, you're probably not doing too hot. But there's also something that um, they didn't mention here, and I don't think that they've mentioned it anywhere else in the paper. But deciding when we extubate an infant, what are the true likelihood that they're going to fail and need intubation? Because I can count literally on probably one hand the number of infants I've seen that were less than 28 weeks gestation and they were extubated and were never re-intubated again. That's the problem, is pushing very, very hard to extubate kids just because the settings are saying that, oh yeah, it looks, we're minimal support, we can extubate and go ahead and do that. That's great. But we need to be a little bit, at least at the centers I've been at, a little more conservative with your extubations, and not just like being, your peeps at 5, let's pull the tube and get you out of here and ventilate or extubate as soon as possible. There's a balance. Yeah, you don't want to overly be conservative with your extubations. If you listen to some of the big debates that we have with some of our like respiratory therapy leaders, they do a really good job of kind of explaining the situation. Is when you look at your extubation rates that you have at a center, if you have a center and it says we have a 100% rate of extubation success, um, which means everyone's extubated and nobody gets reintubated. I would say, or the argument they always make on that one is like, well, then you're not being aggressive enough with your extubation criteria. You're waiting way too long. You're leaving people on the ventilator way too long, because you shouldn't have a 100% extubation rate. There's an acceptable level, but you also don't want to have a 100% reintubation rate, because then you're intubating everybody. You're going to have to find your happy medium that your facility is going to be happy with. Um, but I would argue that you don't even want to make that number. Um, I don't want to put too much weight on that number, because it's going to be varies depending on patient to patient. So whatever number it is, it might be, and it might change over time or go up and down and have peaks and valleys if you like graph it. But just being realistic about, can a 26-week infant who've got one dose of surf on minimal ventilator support, how are they going to survive being off the ventilator? And I also argue, when you're on non-invasive support, if you're extubating a patient knowing that they're going to fail or setting them up for failure, um, during that time, they're going to be struggling, and they can cause a lot of damage to their lungs because of the complications of being extubated, not getting the support that you need. And that can also increase your risks of BPD, along with letting you get so far behind that it's almost an emergent intubation. So being able to know when to extubate an infant, when to reintubate an infant, and just a lot of those factors are very. Um, I don't think we're going to get a lot of science on that. It's going to be a lot of. We're going to rely heavily on personal experience in that, because when we look at that full like evidence-based triangle, we have clinical experience, we have patient preference, and we have research. And we're going to have to find a balance between all three of those when we talk about extubations, reintubations, and those type of things. So yeah, we need to think a little bit more deeper than that one, than just saying like, don't push so hard. Don't take this duration of mechanical ventilation minimized as like something that you're going to get tattooed across your chest or anything. Um, but anyways, we'll get to the next ones. Long modes such as volume targeted ventilation rather than pressure cycled. Remember, it's not pressure targeted or pressure limited. Should be the first choice in infants with RDS or mechanically ventilated. NAVA or non-neurally adjusted ventilator assist. If if necessary, high frequency oscillator ventilation may be considered. So yeah, volume targeted ventilation's kind of is what's popular for good reasons. I mean, that's kind of our safest method when we ventilate our infants, because we are setting a volume target, and it's going to have a internal kind of regulator on that to say we're going to go to that target, but we're not going over a certain pressure. If we have just a certain pressure, it's going to stay at that pressure, and the volume can kind of swing depending on a lot of things that's going on. So yeah, using our volume targeted mode is going to be our safest one, as long as it's like a pressure regulated, internally has a pressure regulated type built into it. So usually we're setting limits along with that, not just saying we're a volume mode. So yeah, they're dual modes, and those are what's going to be best for all of our patients these days. They talk about high frequency oscillatory ventilation, HFOV, a little bit. Not too much detail. We can go back up just to peek at that, because I love the respiratory stuff, and it's good to talk about a little bit more. But when we talk up here about volume targeted ventilation, they kind of get into it. They talk about the Cochrane review, about the development of BPD. They talk about our settings here in case of apnea, which is a European word for it, just apnea. But tidal volumes around 5 per kilo, maximal PIP of about 25 to 30, which is pretty safe. A backup respiratory rate just in case something happens. Be prepared to adjust based on blood gases. But there was one they talked about. Where was it? Here, I think it was. So we talk about using our blood gases in patient situations to adjust our tidal volumes, that we're going to follow an open lung technique that avoids overdistension and atelectasis. Overdistensions can cause PIE, while low pressure and repeat opening and closing of atelectatic lungs can cause inflammation and injury. So this is a very big one that is really harped on when we talk about people with like ARDS or adult respiratory distress syndrome. I don't think we do enough with it in infant respiratory distress syndrome, because there's a lot of information we can pull off a ventilator, specifically our loops, when we're looking at this. And this is definitely a skill that gets developed. You have to be very, very good with interpreting what a ventilator flow volume loop looks like to be, or a pressure volume loop, or what that looks like, in determining what your knowing first what open lung techniques are and knowing how to stay within that safe range when we're doing those ventilator adjustments, because that's a very difficult thing for some clinicians to understand, especially if you don't have a lot of experience with mechanical ventilators. But then we talked about here, collapsing of atelectatic lungs can lead to inflammation and injury. Sorry, it's getting long. I'm getting a little rusty now. But this is when we talk about not just with our kids on the ventilator. So inappropriately setting our PEEP or our distending mean airway pressure, anything like that, can lead to these injuries of collapsed alveoli or atelectatic injury. But this is also what's going to happen if we extubate too early, where those alveoli are collapsing because there's just not enough support. So this is also when you're on CPAP too. So if you're ineffective on your CPAP level, or your CPAP level is below what level you would need to reach your open lung technique when you're ventilating, you can cause your injuries. So yeah, we don't want to make sure we're extubating too early. He talks a little bit, or the group talks a little bit about our settings down here and our PEEPs and our blah, blah, blahs. But we talk about oscillator a little bit, talking about using different hertz, depending on how small your infant is. They talk about continuous distending pressure, but this is where we're really talking more about, to think about it, is going to be using your mean airway pressure. And we talk here about this, again, open lung concept, or this open lung technique, which is determining your optimum level of distending pressure. And this is going to be a little bit more difficult when we're specifically talking about the oscillation ventilator. The oscillator is essentially all I'm going to say from now on for this video. Because when we're on the oscillator, now we don't have that graphical representation of what's going on inside the lung. We have to kind of go by our, sorry, I had something pop up here. But we have to go away. Okay, back to business. So when we are on the oscillator, we don't have that graphic anymore. So now we have to go by the old way that we used to do things to determine optimal open lung ventilation or open lung technique, where we have to increase pressure. It's a whole technique where you increase your pressures to a certain point. You set your oxygen, you kind of titrate the two of them together, and you kind of see where that optimal point is. And then you can kind of leave them there for a little bit, adjust as you need it, and then you might have to actually go back and repeat that, depending on what goes on with your disease process and stuff. And again, this is a very, very difficult skill to learn, because it takes a lot of time and experience, but it is extremely incredible if you know how to use it right. But you can't just go ahead and say that we're going to throw kids on the ventilator or the oscillator without really knowing what we're doing with this. And this is, again, why we say at the very beginning, experience matters. You want to be at centers that are able to adjust these things. But then we look a little bit more closely at this. So we need to make sure we're weaning appropriately. The same 10 hertz for mature babies, a little bit more for that. And then we talk here amplitude based on chest wiggle factor, which I'm going to hold a thought on that. Frequencies are based on CO2 elimination. So frequency, so amplitude is made to control elimination. That's appropriate. Frequencies are only if your amplitude is not adequate, which, that's an important one too. Internally, high frequency can be used in the guaranteed mode. Okay, so there's a little bit we got to unpackage in this situation. So they talk about this HFOVVG. So this isn't available on ventilators in the United States. My understanding of it was because that the mode is not able to get through FDA, because it is not able to, with a lot of these ventilator modes that we have, we're not going to be able to declare that a single mode is superior to another one. Like, they can maybe do non-inferior type studies, but it's the way that these studies are wanting to be done limit our ability to use these modes in the States. Over in Europe, they can do what they want in terms of this, but that's one of probably my biggest gripe with the control the government has about what we're able to practice, but we're not going to get into that. But there is another thing that we have to unpackage here when we talk about the oscillator. So they do talk about amplitude a little bit, and then they talk about chest wiggle frequency, or just chest wiggle, they call it, or chest wobbles. They call it wobble. I guess that's the European term for chest wiggle factor, is a chest wobble. But anyways, when we look at the amplitude, on the ventilator. Yes, we're going to set that at a point where we see that chest wiggle wobble factor adequate, where essentially the infant's wiggling, their chest is wiggling with each of those oscillations, and we want to see it kind of resonating down to about mid thigh level. Now, what happens when we actually look at the ventilator? So you have a dial that you're going to turn, and that's going to be setting what your amplitude essentially is on your ventilator. However, I always have to remind everybody that it's very rare that I find somebody who doesn't kind of get this before I tell them. When we turn that dial, we are actually setting the electronic currency or voltage that is going to the piston of the oscillator. So I can actually pick, I want 5 volts going to the piston, and that's going to determine how much that piston's moving back and forth. The problem with that is everybody looks at the amplitude readout on the oscillator. The amplitude that is listed there is a measurement. So if compliance worsens, your amplitude is going to shrink. And then what do people do? They have to go in and they turn up the voltage, and then their amplitude goes back. I always say that's almost butt backwards, because it's like putting somebody in a pressure mode and then sitting there and watching their volumes, and every time their volumes are low, you're going to turn up your pressure and you're going to turn down your pressure. And it's like, no, that's defeating the entire purpose of having these other modes that can do these things. It's very, very it's a very important thing to understand. It's very difficult to teach, and it's even more difficult to get people on board with it. But if you ever talk to any of the reps from the companies, they can explain this to you, and they can say like, yeah, we always tell people, set your amplitude electric setting, record that, keep it the same, and when it's adequate for chest wiggle factor, and then watch what the amplitude does over time. If it increases, then yeah, your compliance is improving. Baby's probably good to be weaned. You can turn that actual electrical voltage current down a little bit. If it's decreasing, you can investigate. Do you need to suction? Is the disease process worsening? Anything like that. So again, it really would be important to mention more about the amplitude on the oscillating ventilator than what they do here. But again, I could do an entire debate or video on this, which will happen eventually, but it's just important to know we're doing that. I'm also surprised to see that they're not offering any information about the jet ventilator. They don't talk about flow interrupters. They're only talking about the oscillatory ventilator. There's other high frequency modes and devices and stuff like that available, but I don't know why it's not included here. So just keep that also in mind. So coming down here, I know this part's getting a little long because it's my favorite, but we'll go down. When meaning for mechanical ventilation, tolerate hypercarbia, so permissive hypercapnia above 7.22. Great, we know that. That's kind of agreed upon at most centers. Try to keep your PCO2 above 35. So don't over hyperventilate your infants with the ventilator. Keep their CO2 in there where we want it to be, or slightly higher, because if we swing it too hard, it's going to cause some brain injuries. Inhaled nitric oxide should be limited to therapeutic trial with respiratory failure and pulmonary hypertension, and stopped with no response. I'm surprised that this one's not higher. I guess just the research is lacking, but um, nitric isn't going to do a whole lot for true respiratory distress syndrome. It's just going to flood the lungs. It's going to dilate, so you're going to get more blood flow to the lungs, but then you're not going to, if the lungs are in a disease state, that doesn't help. It needs to be, your shunt's just going to increase. You want to have an adequate amount or appropriate amount of blood getting to the lungs, along with an adequate amount of ventilation to optimize your shunting. But beside the point. So caffeine, start with the 20 per milligram per kilogram loading dose, and 5 to 10 of maintenance. That's pretty standard. It should facilitate weaning and prevent BPD. Yeah, A1, I'm not super surprised there. Prophylactic caffeine doses should be started at infants less than 32 weeks. Yeah, I find this interesting that they're recommending prophylactic caffeine doses to babies under 32 weeks, but they don't say prophylactic surfactant doses to infants under 28 weeks. But that's why we're here making videos like this. A little bit more than tapering doses of low dose dex should be considered in babies with high risk of BPD or DEP, or remain mechanically ventilated after 1 to 2 weeks. Yeah, that's pretty standard. If we have an infant who is not weaning or having a difficult time weaning off the ventilator, go ahead and yeah, we'll do trials of steroids to try to get them off. And then lastly, another debatable topic, opioids should be used selectively with clinical judgment, evaluation of pain indicators, refuse routine use of morphine and midazolam in ventilated preterm infants is not ventilated. All right. So there's a little bit behind the scenes we have to think about with this one. So with our infants, well, we'll go a little different with this. So let's think about our adult population. So our adult population, from people I've talked to when they've been intubated and awake and alert and know what's going on, they're extubated and they go, "That was awful. That was terrible. I hated it. It felt so weird. It was very uncomfortable." I can't imagine that that feeling is any different just because you're, this size compared to a full adult. Being intubated is very, very uncomfortable, and we should be doing things to make sure that we're facilitating the use of the mechanical ventilator. So we're improving the patient and ventilator synchrony, because dyssynchrony, or being against kind of what the ventilator is trying to do for you, can cause a lot of problems and lead to specifically things with our infants, things like not BPD, but indirectly BPD, but your IVHs, because it's going to cause a lot of big shifts in your blood pressure. I don't know if I'm like thinking of this improperly, but we need to facilitate ventilator synchrony with our infants to prevent those blood pressure swings, those increases in our CO2 or anything like that. And the only option we really have for that is to do our like mild sedation with our infants. But yeah, mild sedation does come with some risks as well. So I think we need to maybe dig a little bit more deeper in this one. Yeah, I don't think that we routinely want to give infants any of these pain medications or anything like this, because they can cause. Now we have some supportive care measures. So recommendation one, core temperature 36.5 to 37.5 at all times. It's pretty standard. Even here in the States, we're going to go with Celsius on this one. So it's about the same that we'll do. Next, most babies should be started on fluid 70 to 80 milliliters per kilogram per day in a humidified incubator. Although some may need more, fluid should be tailored individually based on serum sodium, urine, and weight loss. Yeah, that's pretty standard for most places that I've um, talked to. It's just going to depend on the infant, how adequate that humidity level is. And that humidity level, I don't think we got into a ton of information, yeah, about this one. I'm surprised they didn't say more about skin to skin care down there in their measurement. But what I'm looking at is they don't really talk about humidification levels or anything like that. But again, this is focused on respiratory distress, so that's why they didn't get into that areas. But we just want to make sure that we have a evidence-based protocol that we're using when we're monitoring or starting heated humidified incubations or incubator therapy with our infants, because we want to make sure they have an adequate amount of fluids coming in to replace any that are going out. Next up, parenteral nutrition started at birth or soon after birth. It's going to take some time to get to the NICU and get everything set up. Amino acids start at 1.5 to 2 grams per kilo a day. Build up to 3, but don't go over 3.5. Lipids 1 to 2 a day. Building up to 3 is tolerated. That's pretty standard. It's just TPN therapy that most people are going to be pretty familiar with if you've worked in the NICU at least. Enteral feeding should be started with mom's milk starting at day 1 if hemodynamically stable. Full enteral feeds can be considered in infants over 30 weeks. That's pretty well. Yeah, I didn't think we talked about it. Yeah, they didn't really go into it a whole lot. They just gave it a little blurb down here. There's debates about what this actual volume that we should be starting with, because yeah, they have the risk of neck, and they just have to make sure that's clear that we're going to be considering all these factors. Because again, 26-week infant's not going to come out with their only problem being RDS. They're going to be high risk for neck and other infections, other complications like that. But mother's milk is going to be ideal. We have other stuff available to us, but Again, this is just kind of standards with that. And lastly, they talk about RDS and antibiotics. Again, part of our antibiotic stewardship is only in starting in antibiotics when we have an indication for them. Infants, it's a little, in neonatology, it's a little different because we'll start prophylactic antibiotics a lot more than you would ever see in the adult or older populations. But that's pretty standard. If you know you need to use antibiotics because you have a high risk for an infection, go ahead and do it. And our last section here is on managing blood pressure and perfusion. So this one goes to say treatment of hypotension is recommended when there's evidence of poor perfusion, such as oliguria, acidosis, poor cap refill. Treatment depends on cause. It talks a little bit about the hemodynamic significance of a PDA and medications to close it. And paracetamol is preferred when there's thrombocytopenia or concern to renal function. And then some thresholds for transfusion and requirement of respiratory support. So this section is pretty straightforward. It just says that if we are having symptomatic hypotension that's causing poor tissue perfusion, we probably should do something about it. Just pretty straightforward, even though it's got low evidence there. And it talks a little bit about PDA. The PDA is interesting because it can cause some increased risks for a lot of the things we don't want. However, a lot of times the management and strategies of closure are facility dependent, depending on what medications they like to use or would prefer to use, and what's their threshold for like surgical intervention versus not. So it kind of depends on the type of unit you're in and what their protocols and policies are at that point. And just it's pretty straightforward. If we have a concern about renal failure or some other issues, we're going to go with the alternative that's a little bit safer. And then the transfusion thresholds are usually also covered by unit protocol or policy. And maybe this will influence them a little bit to make some changes there. And then looking at the last of it, we have a couple conflicts of interest from some of these authors. And the other one that was notable is the grant funding. So this was completed with a grant through this pharmaceutical company. This is the company that makes that Curasurf or Practin, or the Curasurf is the brand name of Practin Alpha. So that's, we can take that with a grain of salt. They do recommend Curasurf in the article, but I've looked at some of the research on this, and the Curasurf is the superior product on the market right now because of some specific things about what's in their surfactant that the others are not. And then it talks about author contributions, which is kind of a newer thing in research. Back in my day, well, a few years ago, a lot of medical students always loved to get on writing papers with labs, and they would do some of the work that may not be directly the research. They might be doing some like the grunt work or just like the paper writing or something like that. And they wanted their name on all these papers, even though they didn't really do a whole lot because they were kind of padding their resume to get into medical school. But we have switched that a little bit to be that kind of outline that we want people to actually contribute to papers to get their names on it. But all right, so this is that consensus statement. A lot of it's pretty good. There are some things that are going to be debatable. The good thing with this is it's not necessarily a research article. It's more like a it's not a meta-analysis. It's a little bit different because they kind of made consensus and they took into account what those studies have found, and they didn't necessarily report like statistical significance of different interventions, but like they're balancing. It's all that part of that evidence-based triangle. They're using what they have seen, what's recommended, and what they've experienced in their practice. So it's not going to be like a research study comes out and it takes 10 years for that research to ever change practice. Because when we're looking at research studies, like this is the global sphere of like everything that's known, and like a new research study comes out and they go, bloop, all right, we expanded the bubble or that corner of the bubble by that little bit. But this is kind of consensus. It kind of looks at everything and what's actually happening at the hospitals out there. So it's pretty good. I hope you enjoyed this one. It's a little bit different, but I'm hoping to get some more of these coming to you so we can look at some different researchers out there and you can understand why we're making some of the decisions we can make. And then in the next couple of videos, we have some real special things.